My name is Susan Block, and I'm a retired circuit court judge and a lawyer now specializing in family law at Paul Kamazine and Blumenthal. I'm also very proud to be a member of the steering committee of the Jewish Coalition on Racial Equity, which is a part of the St. Louis Jewish Community Relations Council. Guided by Jewish values, the JCRC educates, collaborates, and mobilizes action on issues important to the Jewish community. On behalf of our co-sponsors, which include the Interfaith Partnership, YWCA, the Mirawood Center at Covenant Place, the National Council of Jewish Women St. Louis Chapter, the Peace and Justice Commission of the Archdiocese of St. Louis, and the nonprofit organization Before Ferguson Beyond Ferguson, I'd like to welcome you to today's program, the second of a four-part series that will examine systemic racism in four areas: economics, access to healthcare, the environment, and courts. Our format for all four of these forums will include a perspective from clergy members, remarks from a keynote speaker that will dive deeply into the issue, and then an opportunity to hear from a St. Louis citizen who could share the real-life challenges of systemic racism. We will also include resources to deepen your learning and take action to improve racial equity in our region. And finally, we will leave time to move into breakout groups to spend some time discussing and reflecting on what we have heard today. To begin with, I'd like to introduce Alyssa Banford, the Director of Civic Engagement for the Jewish Community Relations Council, to provide an overview on systemic racism and review community standards for today's meeting. Alyssa?
Good afternoon, everyone. Thank you so much for joining. So before we jump into our program today, we'd like to go over some vocabulary to make sure we have shared language when we talk about racism. I apologize to those who have heard this intro in the last session, but we think that it's worth repeating. So you'll hear it at the beginning of every session. So we want to essentially create some shared terminology. So let's start off with individual racism. Individual racism refers to an individual's beliefs, attitudes, and actions that perpetuate racism. So examples include telling racist jokes, not hiring someone who's qualified because they may have an ethnic name, etc. It also encompasses collusion, which is the act of going along with accepting things the way they are. You also may be less familiar with a subsection of individual racism called liberal racism. Liberal racism refers to statements or actions of mass denial, minimization, defensiveness, and guilt. So someone claiming that they understand the pain of racism because they experience a different form of oppression, or someone saying they're colorblind. These are examples of liberal racism. Next is cultural racism. This refers to representations, messages, and stories conveying the idea that white behavior or values are better than others. You'll see cultural racism promoted in advertisements, TV shows, movies, etc. So to give you some examples, what does the bad guy wear? Black. What does the good guy wear? White. Angel food cake is white, but devil's food cake is black. So those are some examples of cultural racism that you hear day to day and you might not even think about as being racist. So not only do those ideas perpetuate racism, they also enforce internalized racism within people of color. So then lastly, there is systemic racism, which has the subcategories of structural and institutional racism. So a lot of these terms are used interchangeably, but for our purposes, we're going to define them as separate. So an example of institutional racism can be found within the government policies that explicitly restrict the ability of people of color to buy loans or improve their homes in neighborhoods with high concentrations of African Americans. This is also known as redlining. That's an example of institutional racism. Structural racism is the normalization and legitimization of dynamics. So an example is the huge difference in life expectancy between the Black population and the white population. And that's exactly what we're going to explore more in this presentation today. So then take structural and institutional and put them as a whole. Systemic racism is the distribution of resources, power, and opportunity which disadvantage Black people and people of color. Where can we find it? Everywhere. It's found in banks and schools and companies, government agencies, law enforcement, military, etc. So what's a result of systemic racism? Also found everywhere. It creates disparities of wealth and income, employment, criminal justice charges, home ownership, levels of education, representation in politics, health and mortality rates, and so many more areas. But systemic racism also shows up in other ways too. So think about how some schools or businesses prohibit dreadlocks, cornrows, or braids in their dress code. That's an example of systemic racism. Our topic today, healthcare disparities, is a direct result of systemic racism perpetuated by individual racism. So these graphics here are from the For the Sake of All report that came out of Washington University and focused explicitly on St. Louis and the surrounding area. Although the report was published in 2014, the findings are still relevant today. You'll see the map on the left has concentration of the African American population. And you'll see that that orange area, that's where the highest concentration of African Americans is in our city. Now then look at the map on the right, and you will see that in those same areas, we're seeing lower life expectancy. So with average life expectancy being 70 or 67, and yet in the areas where there are more white people, that life expectancy goes up to 85, 82, 81. It's a big difference. So there are a tremendous number of factors that go into play for creating those huge health disparities. And we don't have time to go into all of them, but just to give you an example of some of the pieces of the puzzle, you have food deserts, which is lack of proximity to healthy grocery stores that have fresh fruit and fresh vegetables, level of education, long-term stress, socioeconomic status, the quality of neighborhoods, so whether there are sidewalks and playgrounds, whether it's safe to play outside, etc. Of course, proximity to pharmacies, hospitals, doctor's office, access to healthcare, and prenatal care. All of these can prevent equitable healthcare. So what are we striving for? We are striving for equity. What's the difference between equality and equity? Well, equality is giving everyone the exact same resources. But equity is the distribution of resources based on individual needs. And it takes into account the differing circumstances in order to reach an equal outcome. So I know this is a ton of information. Again, we're going to go over these before each session, and hopefully by the end you'll feel very comfortable using these terms and understanding the differences in types of racism. So before we jump in, we know that these topics are also very challenging, and we have a list of group norms to help guide us through conversations. So we want you to keep these in mind when we do breakout sessions later, and then keep them in mind as you go forward and you have conversations about race. So number one, hold the assumption that everyone is coming into this with the best of intentions. Number two, we will not deny the reality of someone else's lived experiences. 3, know that you may not agree with everything that is discussed in the meetings and programs, but please be open to hearing other perspectives. Next, allow others to finish their thoughts before adding your own. Beware of how much space you are taking up in the meeting and adjust to step back in order to allow others to step up. Be open to continued learning and suggestions, especially if there's a misstep or a mistake. And then finally, be prepared to sit with some discomfort and know that that discomfort is towards the path of growth. That's all I have for you all. Susan, I'll turn it back over to you.
Okay, thank you, Alyssa. Now it's my honor to introduce Reverend Donna Pupillo. She is an ordained United Church of Christ minister who is a registered nurse and passionate about healthcare and faith communities and faith-based nonprofits. She currently serves as the executive director of Deaconess Faith Community Nurse Ministries, where she works to create communities of holistic health and wellness for low-income and vulnerable adults through exceptional faith community nurses. Reverend Pupillo, we are so honored to have you with us today to explore the UCC imperative for racial equity.
Well, welcome everyone. I'm glad to be with you and to come and share some perspective, particularly from the Christian tradition of the UCC. For us, we often say our God is our healer and our creator. And that image in our minds it talks about creation, and also at the same time talks about creation both being broken but being whole, and in need of healing but as a healer. You know, we say every person is created in the image of God, or the imago Dei of God, and is valuable to God, and therefore has access to healing and wholeness because that is a part of who they are. Currently, in my tradition, this is the season of Lent. It is the time between Ash Wednesday and Easter, and traditionally during this season, we focus on how can we have complete and whole relationships with God, with one another, and with all of creation. We take a look at how can we repair, restore, and enhance in tangible ways our relationships that bring healing and wholeness to our world. We look at scriptures and we see in scriptures healing, and we delve deep into what that means. In the Old Testament, we have the story of Naaman and his leprosy and of him being healed, having access to that healing. And in the New Testament, we hear the stories of Jesus, who healed the blind, the lame, the sick, and all the stories talk about restoring, bringing to be in the world love and compassion of God for all people, that everyone has access. One of the stories I'm particularly drawn to is the one of the Good Samaritan, which tells how the Samaritan cared for an injured person on the side of the road while others passed that person by. Wow, not passing somebody by, but spending time and paying attention and staying there, and then taking that person to a place where they could be cared for and healed, and doing that work of justice and compassion together. The word compassion, it means at a deep level a feeling in your gut, a gut level for another person. And that is the call for us as followers, to have that gut level care and compassion for all people, that we don't pass by, that all have healing and wholeness. You know, we learn about the teachings of love and fellowship and the basis for human relationships, and they do include health and healing and wholeness, and that compassionate living is a part of it. It's no surprise that then we are prepared as disciples of Christ in my tradition to be healing agents, to walk in God's kingdom, being about justice and healing for all. And being that healing agent is what it means to bear Christ's image in the world, that humans live in community. We know that even more so now in the pandemic, that we are so longing for community, for it to being together, and that we are so longing for a community that is whole, that everyone is a part of. We are relational. We have creative and purposeful ways in which we live, and God is relational and creative and purposeful. And as a community of faith, we express that dimension of being in the image of God, being connected to one another, having the hospitality that welcomes others, doesn't shun them, and brings them into the community, that has an ethic of mutuality in that pursuit of wholeness and healing. The walk of justice for us in the United Church of Christ is very much about healing and wholeness, so that all are welcomed at the table. So may we today consider that as we talk about healthcare and wholeness.
Thank you so much, Reverend. It is now my pleasure to introduce our keynote speaker, Riisa Rawlins-Easley. Riisa Rawlins-Easley is the Chief of Staff at Regional Health Commission, a collaborative effort of St. Louis City, St. Louis County, the state of Missouri, health providers, and community members to improve the health of uninsured and underinsured citizens of St. Louis City and County. Riisa Easley has served in leadership positions as an independent consultant for various nonprofits in the St. Louis region since relocating to the area in 2004. She has over 20 years of experience in cultural competence and stigma reduction, integration of primary care and behavioral health, and positive youth development. She has a BA in political science from Loyola University, Chicago, and received a master's in social work at the Brown School of Social Work here at Washington University. She is currently pursuing her PhD in political science at the University of Missouri, St. Louis. She serves as a member of local nonprofit boards and committees, and was a member of Focus Leadership St. Louis Class 41. We are so fortunate to have her here in St. Louis and with us today. Ms. Easley.
Thank you so much for that introduction, Susan. It is really my honor to be in the presence of those of you like-minded individuals who are interested in having this discussion and really diving into the things that make us unique and that also challenge us within our region. So I'm going to talk about healthcare and disparities as relates to healthcare, but I'm going to take a little bit of a different tact to do that by talking about the organization for which I work. But I do want to, before I dive into that, share some resources with you that I think are really exceptional in helping to understand the institutional components of how race is baked into our healthcare systems, and then how it sometimes comes about in interpersonal relationships. So there are two texts. I never know how to do this when I'm sharing, but I will share with, so they can share the text with you because I'm not sure how to, but it's of Medical Apartheid by Harriet A. Washington that talks about the history of medical experimentation on Black Americans. The other text that I'd like to share with you is a more current text, it's Just Medicine, which is a cure for racial inequality in American healthcare. This one is by Dana Bowen Matthew. So I will drop this information or share this information with the hosts today so that there is some additional information that can ground the conversation that we will be having today. I share those with you because I think it is a good way to talk about and to explain where we are as far as how we got to where we are today. And I'm sharing my screen with you, and I'm now having to remind myself how to go into presentation mode because everything looks different once I share my screen. So if you can bear with me momentarily, there we go. There we go. So I'm going to talk to you from the context of the St. Louis Regional Health Commission, because really the founding of the St. Louis Regional Health Commission is rooted in the existence of systemic racism and how it has played out and borne itself out in healthcare. We were speaking briefly about the disparity in outcomes and the way that I have in listening and speaking and having these conversations, how I choose to talk about that is the injustice in healthcare outcomes. And the reason why I use that terminology is because the outcomes that we see are not based on a genetic predisposition to folks not doing well in these certain chronic diseases and conditions. But there are a lot of historic implications. There are a lot of social determinants of health, which were alluded to earlier, that impact our healthcare outcomes. And when I say social determinants of health, I'm referring to how our environment, our access to healthy foods, our access to safe spaces impacts our ability to do well and to be well. And so the Regional Health Commission centers its work in each of these areas because of these conditions. So if you're not familiar with the RHC, it's a network of individuals with a responsibility and a commitment to improve the health of St. Louis. It's important for us when we think about improving the health of St. Louis that we not just think about health overall, but that targeted universalism that allows us to really focus on individuals who have been underserved and have the least access and the most severe outcomes. So for us, the mission is really around increasing the access to care. It's about improving outcomes. And it's also about helping to close the gap in the healthcare disparities that we see in our region, or the healthcare injustice that we see in outcomes. St. Louis Regional Health Commission has been doing this since 2001 as a response to the closure of the last public hospital in St. Louis. So again, if you think about institutions, if you think about infrastructure and how all of these things come into play to influence a community's well-being, this is a perfect example. So the last public hospital closed. Who were the patients who were mostly served by public health hospitals? What we call the safety net populations, or people who were uninsured or underinsured. And if you look at the maps, similar to what was shown for the sake of all, you'll see there's a great intersection between those who are living in impoverished communities, who are uninsured and underinsured. And if you overlay that with race, because in St. Louis, there is a long history of segregation, intentional segregation, that really helps to inform what those maps look like. So the Regional Health Commission is comprised of a board of commissioners, some of whom are appointed. We have our legislative representation. We have appointees that are from the governor, from the mayor. We also have all of our major hospital systems who sit on the commission, as well as our health departments, representation from our behavioral health community, as well as our federally qualified health center. But the engine that allows us to continue to understand how this influences different stakeholders is really our advisory board structure. So we have Provider Services Advisory Board, who are healthcare practitioners who can give us their insight and perspective on how all of these issues show up within their exam rooms and as they're providing care to individuals within St. Louis City and County. In addition to our Provider Services Advisory Board, we have a Community Advisory Board. I spoke about the social determinants of health. So these are leaders within the social service sector who provide information and insight into how within their sectors where they provide service, they're seeing this show up and how health matters and what the questions and concerns are within the communities that they serve. I am biased, I will say, because the newest board that we have that I am most excited about, because this is a new strategic direction for us, is our Patient Advisory Board. Why am I most excited about that? If you're going to have expertise and really dive into a topic area, it's really critical that you engage folks with lived experience who are on the ground and can tell you, okay, so I know that you think that this is how it works, but here's what my experience has been. So these are individuals who are uninsured or recently uninsured, who may be receiving Medicaid or the Gateway to Better Health program that I'll talk about a little bit later. I pause to let you know these structures within the Regional Health Commission, because I also would invite you, if you were interested, to join, log on to our website, and I can share that link as well. And if you're interested in participating, here's how you can help to influence. So as an MSW, one of my lenses or my perspective is really solutions oriented. And so we talk about the why, and it's important to ground ourselves in how we got to be where we are today and the conditions that exist. But I think it's also important for us to get to a point where we can shift the conversation to understand where our power and influence is to help to transform the systems that we are now living in and living with. Where are our levers for change? And so this is one that I invite you to explore. So the individuals that we serve within the RHC are individuals who live in poverty. And it's important to understand what that means and looks like in St. Louis. I won't spend a lot of time. This, again, I think dovetails nicely with the slides that were shared previously that were from the For the Sake of All report. So the federal poverty level in 2019 for one person was $12,490. For a four-person family, it was $25,750. And I think that's just an important marker to keep in the back of your head as you're thinking about how folks are navigating these systems and the resources that they're using in order to do so, and what that would look like, what that would mean. So in the St. Louis region, 13% of adults live in poverty. 39.8% of children live in poverty in St. Louis City. And so that's important to us. And again, targeted universalism encourages us to look at the folks with the greatest need to understand how we can provide resources and support. So health coverage in Missouri and St. Louis. No Medicaid eligibility for individuals unless they were a parent, pregnant, disabled, or they were children. On August 4th, you may be aware, this is something that we spend a lot of time and energy around, Medicaid expanded. That opens up access to healthcare for another 200,000 people. So the Gateway to Better Health program that we ran is going to phase out as more folks have access to coverage. The Medicaid eligibility for parents in Missouri, $5,665 per year for a family of four. So that's up to 22% of the federal poverty level. And this is what's used to determine eligibility for health insurance, right? And if you think about in the whole context of your well-being and your day-to-day life, how important your health is and the health of your loved one is, this conversation becomes really important. When you think about, again, all of the social determinants of health, there are factors that, the push and pull factors that influence our overall well-being and our experience of trauma when we think about being able to have equitable access to those things. That has been an ongoing problem in the St. Louis region. It has been nationally, but our focus is how do we understand what systems and individuals are in place, and again, where our opportunities are to help transform the systems to create more equitable access so that the outcomes that we're seeing will start to, the gaps will start to close. So this chart that I'm just showing you right now is just, again, looking at healthcare disparities in the St. Louis region, looking at the percent uninsured by zip code and the health rankings by zip code. And I like to show these maps because I believe that you get a real solid picture when you're starting to look at all of these intersections. If you have in the back of your mind the orange sections that you were seeing in the maps from the For the Sake of All report, and you look at, again, some of these disparities, very healthcare disparities in the region, so the percent uninsured, and you look at where that's located, and that's the very dark green. You start to see a very similar picture. So oftentimes we will use zip code data as proxy. And if you're familiar at all with housing policy in St. Louis, and you're familiar at all with, you mentioned briefly redlining, how that has impacted our region. St. Louis is one of the most segregated regions in our nation. And I say that because when you look at disparity and when you look at access to healthcare and when you look at health outcomes, you will see it around zip codes. You'll see clusters around zip codes. And so I just think it's important for us to understand what we're saying and why we're saying. Why did it come to be that way? Where are our health centers and where are resources in relationship to those zip codes? And then you get a clearer picture that it's not the interpersonal interactions that are always the most damaging, but those that have the most long-lasting, pervasive effect are those that are entrenched and embedded into the system. So when you think about our current context as we're navigating this dual, we often talk about the dual pandemic of COVID-19 and structural racism. And you think about where testing sites were initially elevated when we were starting to understand this pandemic and trying to get a handle on it. When you think about now that vaccines are available, where those vaccination sites initially were cropping up. And then you think about the disproportionate impact and how the majority of the disease, mortality, and illness was borne by Black communities. You can see a disconnect, and you can see why it's important to have this conversation about structural and institutional racism, because it allows itself to embed in ways that we would not necessarily realize or uncover without these conversations. So I just wanted to make sure that I made a finer point about that and brought that to your attention and for discussion as we move forward into our breakout groups later today. So the St. Louis healthcare safety net system, this slide just shows you some of our partners and where they're located. They have been and continue to be a really critical resource in addressing and eliminating the gaps and the disparities that we see in healthcare access and outcomes in our region. So within our region, our federally qualified health centers include Affinia Healthcare, Betty Jean Kerr People's Health Center, Family Care, and Care STL. And our St. Louis County Department of Public Health serves as an FQHC lookalike because they also do see patients. A lot of, again, the safety net population has an opportunity to still get quality healthcare by joining with these partners. And so our work at the RHC is to help to understand what the needs are and to help elevate the work that they're doing so that we can, again, tend to the disparity and eliminate the disparities that we're seeing in our region. One of the ways that we do that is really critically important is to hold ourselves accountable. So when the RHC was established, one of the requirements to receive the federal waiver for our funding was that we would regularly report on how we're doing. You know, are we actually accomplishing the things that we set out to do? Are we actually making any difference in access to care for the most underserved populations, for those with the most severe health outcomes? And the way that we do that is with a release of an access to care data book. And that helps to show data that's disaggregated by race, that's disaggregated by insurance status, and in a number of different ways, so that we can, again, continue to hold ourselves accountable, not just for seeing or identifying the problem, but actually implementing interventions to help close some of the disparity gap. And so again, I'll give you a link to our website if you're interested in looking at what data is available and seeing how we're doing in the longitudinal data of our progress since the last public hospital was closed in 2001. Another way that we lean into this commitment is with our partnerships. So one of the things that the Regional Health Commission has been really careful to do is to listen to community and all the stakeholders. So community defined really broadly. So the legislative, executive, provider, community service organization, and patient communities, and all of those intersecting points, and what the greatest concerns, barriers, and needs are within community. Through those conversations, we have on several occasions had an opportunity to then think about okay, well, what intervention needs to be put in place? How do we address this concern? So the partners that are represented on this slide are actually 4 organizations who began out of pilot conversations and programming within the Regional Health Commission, and now have gone beyond and live lives of their own and provide invaluable resources and connections within our community. You may have heard of the St. Louis Integrated Health Network. I shared a couple slides back, each of the partner organizations that exist with the federally qualified health centers in the region. And the St. Louis Integrated Health Network keeps that constellation of health centers, in addition to our, again, hospital partners, their chief medical officers, and our schools of medicine, again, to have that a really specific lens in community. And one of their priorities has been working on racial disparity. And how do we, as we're thinking about and having these conversations, look internally to understand the ways that we perpetuate and reinforce the trauma of racism within our healing environments. And so if we are really committed to transforming the system and creating change that's going to improve the experience and outcome of the people that we are committed to serving, it is going to require difficult conversations and some really hard assessment of where we are and how we're perpetuating and feeding into that. So it has been an absolute honor to really listen to some of those conversations and to listen to the willingness of our health community in the region to really identify and acknowledge where we're falling short and to put some safeguards in place so that we can move forward and do better, and to really look at how can we make some significant changes if we're all leaning together in the outcomes in our region. Health literacy media is another one that helps us to think about how do we make language accessible and connect with folks in ways that they can find themselves and understand. Behavioral Health Network of Greater St. Louis, very similarly, but for the behavioral health community, where there is an opportunity for stakeholders to convene around the table who are providing mental health and substance use services for our underserved populations here in the region. And their footprint is a bit broader than ours. They include a couple adjacent counties as well. And then most recently, Alive and Well Communities, which has been phenomenal to watch the conversation shift in community to acknowledge and understand the impact of trauma and how it influences our well-being, and how we sometimes, again, perpetuate that trauma even when we're trying to do good, right? And so I think, again, that's why these conversations are really important, because I don't think you'd be here if you weren't really interested in doing good, right? In changing the conversation, in moving the needle forward, and in creating equitable experiences and opportunities for folks. But often in doing that, we neglect the first step of that self-assessment, of that organizational assessment. And we are looking now for ways and tools and resources so that we can measure, so that we can monitor, so we can evaluate and continue to improve. So those are just a couple of the organizations. Gateway to Better Health is the insurance. It was a gap insurance for folks who did not have or did not qualify for Medicaid, again, with after the expansion of the Affordable Care Act. But now, as of August 4th, that is no longer, Medicaid has been expanded. So what we thought was going to be a 1-year project turned out to be a 10-year project. But that's one way that we have really leaned into our commitment to addressing health inequity in our region. The last thing I want to spend some time, or two things I want to spend some time talking about that I'm really excited about, is Prepare STL. So again, I referenced the pandemic, the dual pandemics that we're navigating right now. And our response, as we looked around, we noticed that people were asking questions, people were answering questions, and it was to providers, it was in community, but not within the communities that were most significantly impacted. And so the Prepare STL campaign was actually by community, for community, in community. So people who actually were living in the community, who were able to connect and understand what the concerns are and speak to those questions, were able to connect with folks and to give PPE kits and to give flyers and information real time in language that folks understood, the ways that we're engaging. We are now pivoting and just started a campaign now that the vaccine has been released that is going to over 100,000 households that give clear facts and information. What is the virus? What does it mean? What does it do to your body? Why do you care? What is the vaccine? Why was it developed? What are some considerations so that people can have informed choice? So our goal really is not to tell folks what to do, but to give them all the information that they need and to get out of the way, because we trust their wisdom and their ability to be able to make the choices that are best for themselves and their community. We also will have a podcast, What Matters to Me Most, with Dr. LJ Punch. We also are doing some speakers panels with providers who can give some information. And we're recruiting 300 community champions to have small conversations, over 600 conversations, 2 times 10 folks apiece, to be able to, again, share clear information and to just answer questions, to talk to what people are, speak to what people are worried about. So I'm interested, really excited about that, and we'll share information in case you might be interested in being a champion or would like to share that. We're also leaning into our state and federal health policy, because we understand that there is policy that encouches all of this. And as we're advocating on the ground, it's going to take a dual approach, where we look at and think about an advanced policy that is going to allow us to address some of the entrenched, embedded, both de facto and de jure discrimination that we see within our community. So that is what I have for you. I hope that was helpful and informative, and that you found some ways that you may actually be interested in engaging in this work and conversation. So we are not just talking about the problem, but also giving you some resources to engage in the fight to address some of the disparity we see in our regions. Thank you so much for allowing me to have time to speak with you today.
Susan, I believe you're muted.
Thank you, Riisa, for that enlightening presentation. If any of you have a question for Riisa, please type it in the chat, and we will have time for questions and answers after our next speakers. To move to the local portion of the program, it's now my pleasure to introduce Jeannette Cooperman, a member of the St. Louis Media Hall of Fame and staff writer for the Common Reader. Before that, Jeannette served as a staff writer at St. Louis Magazine for 12 years. She received the Writer of the Year Award at the 2019 City and Regional Magazine Awards. Jeannette is a storyteller for the Before Ferguson Beyond Ferguson project, whose mission is to share the stories of people of color in the St. Louis region as they are challenged by systemic racism. Jeannette will introduce Courtnisha Rogers.
Thank you, Susan. As you said, I'm part of a group of journalists that have been writing stories for the past 3 years, exploring racial inequities. Our stories have appeared all over local mainstream media in the St. Louis Post-Dispatch, the Riverfront Times, the St. Louis American, St. Louis Public Radio, St. Louis Magazine, The Jewish Life. During the pandemic, we have focused on neighborhoods in the 63106 zip code. Why 63106? Because of that landmark study that you've been hearing about tonight. Researchers at Washington University's Brown School looked at statistics and health outcomes across the map, and they found that in our entire region, 63106 had the most problematic social determinants of health. Here's a revealing data point. A child born in 63106 in 2010 would have had a life expectancy of 67 years. Contrast that to a child born in 63105, a Clayton zip code that is fairly wealthy and mainly white. That child could expect to live to 85 years of age. That's a difference of 18 years of life. And that data predates the pandemic, which means the discrepancy has only gotten worse. My fellow guest today is Courtnacia Rogers, who has been raising 3 beautiful Wrigley preschoolers and running a home business from her apartment in 63106. So far, she has kept her patience, and she and Angela, Angelino, and Angelo are healthy and COVID-free. Lately, she has been weighing the benefits and what she sees as the great risks of the vaccine. Courtnacia, I don't know if I've ever met somebody who is as hopeful and as resilient as you are. And yet, when we first talked, you told me that this pandemic was, I quote, the scariest thing in this life. So tell me what you've been doing to keep you and your kids safe, first of all.
We have been wearing our masks. We have been staying in a lot. I actually have my kids doing virtual learning right now. They have not been in person since this whole thing started. Lots of washing our hands, just talk to them about safety, and just talking to them about what's going on and passing germs, and just trying to stay in the house and away from, a lot of people.
Yeah. And how are you feeling about the vaccine?
I come from a family where we do not believe in those type of things. I have not been vaccinated. My kids have not been vaccinated. I am not going to unless we have to, unless we are forced to. I don't feel like the vaccine will help chances of, not getting it or prevent it.
Yeah. One thing I remember when we first talked, I mentioned that the rates were higher. The disease was hitting people who were Black harder. And you said that you were surprised by that because you had seen on social media something that said if you were Black, you couldn't get it. Was there a lot of misinformation flying around last year?
There was a lot of misinformation. We were told people of a certain skin color that carried a certain skin could not be affected by the disease. As time went on, we are seeing more people of color actually affected than any other race. So it was very shocking because when it first started, a lot of people of my race believed that we could not get COVID.
Do you trust healthcare?
I trust healthcare to a certain standpoint. I wouldn't give it all of my trust, depending on the locations we are speaking of.
Yeah, I was curious about it. You're in 63106. How do you think your healthcare and the care available for your kids would be different if you lived in Clayton?
I think services would be faster. I think services would be more genuine. I think that they would actually take the time out to see what's going on. Local hospitals, here we're in a waiting room for 5 to 6 hours. We are told to leave even when we're sick. The care for Blacks is very horrible.
Yeah. Tell me a little bit more about what you mean by more genuine.
I would say when we go to the hospital, it's not really caring, I don't think they take time to evaluate the person. I think it's more so they just try to get you out. Like, it's just like in and out. It's like, I don't really care what's going on. It's like, let's just get you in and out because, we have a long shift. So, yeah.
Yeah, move you through.
Yeah.
If you could change the system, if you could do something to improve healthcare for you, where you are, for your kids, what would you do? Wave a magic wand.
If I could wave that wand, I would put more workers on site. I would open services in more locations for this community. Definitely more locations and more help, more workers. That would be the number one. And I also would try to lower the cost because even though we might have insurance, we're still left with a lump sum. you know. So definitely the prices of services.
Yeah. Have there been times you have tried to economize and figure stuff out on your own?
Oh yeah, plenty of times, because I just couldn't afford the visit. I couldn't afford the ambulance. I couldn't afford to stay. Some of the medication I couldn't afford that at times. So there's a lot of times where I'm like, hey, let's doctor up at home, kind of like what I'm doing now. Like, let's get the 7-Up and the soda, because I know if I go to the hospital, it's gonna be about $300-400 just for a pop, you know. Yeah.
Yeah. What worries you or concerns you about your health or your kids' health? Is there anything in the future that you worry about?
I more so just worry about the virus and any viruses that are new to come. I practice vegan with my kids, and I try to eat healthy and, you know, work out with them. So they are pretty healthy. I don't have any health concerns at this point, but I do.
You're doing okay?
Yes, he is.
And how close is it? How easy is it for you to get to, say, a pediatrician or to a hospital if you need to?
Now it's a little harder. Now a lot of things are by appointment. They do have a lot of visits that are virtual, like what we are doing. It is very hard. Walk-ins are limited, you know, because of the space and environment.
Mm-hmm. What if we're not in a pandemic? Is it easy to get to places, or do you have to?
Yeah, if we're not in a pandemic, it is 10 times easier. Everything is closed down. Everything is curbside. Everything is by appointment. The virus and the shutdown makes things so much harder.
Yeah. Somebody mentioned to me that he lives in 63106 and he felt like nobody in terms of public health was doing much to actually enforce lockdown. You know, like businesses were still open early on, and he felt like nobody cared about your the kind of information. Or
I think that is very true, but I think over time they have got a lot stricter. There's a lot of places they have violated the health policies, and they have been closed down.
Okay.
So I am a lot of places in the area get like a 30-day probation, a 30-day close down, or have to close early because of violating that.
Okay. What about preventive care? Do you feel like people in your neighborhood, like friends that you know, get all the screenings and checkups that are recommended, or is that expensive and hard to get to?
I think that is expensive and hard to get to for most people that are not qualifying for benefits to help. So, you know, that's very hard to get to. You don't have, you know, the benefits to do so. So I feel like a lot of them, you know, don't get the screenings or don't take the appointments that need, because it's kind of hard to even get help.
Yeah. What do you think in terms of general living conditions would make you able to be healthier, you and your kids? Are there any changes in your surroundings, in your atmosphere that would help?
I think that the neighborhood could be cleaner within itself. We have a lot of problem with like pests and you know, people not keeping clean, and if the neighbor isn't clean, I mean, our house is ruined as well, you know. So the environment, the trash, the alley, you know, causing a lot of unhealthy things, you know. And I also think like a lot of the buildings can be remodeled and can be screened for lead and, you know, things like that. I just think we are living in a poor environment, and some of those things are even expensive for whoever we're housing through. So yeah, it's just really kind of hard to have a healthy environment.
Yeah, I've heard trash pickup can be really uneven and
yes.
Okay. Any thoughts, other thoughts you have about the health system?
I don't have any thoughts about the health system really. I just feel like care should be, it should be more care. I actually do see them building a hospital like down the street in 63106. So yeah, so that's like a major thing. I just feel like the cost of insurance, a lot of people could be helped more with the billing because most of the bill is left on us and it's left on our credit and we suffer in the end. You know, so yeah, so a lot of us don't even want to risk that visit to have that bill.
Right.
Yeah.
There been any times when you've done it at home and tried to take care of the kids and later you thought, oh shoot, I should have gone?
Yeah, if it gets really bad, I'm like, you know what, let's get it. You know, hey, it's nothing more I could do, but I would try to do everything before I just say, hey, let's go to the hospital.
Yeah, exactly.
Thank you very much, Jeannette and Courtneisha. At this point, we're going to move on. I'd like to introduce Amy Hammerman from the National Council of Jewish Women to offer 2 action items. Amy?
Hi. In terms of legislative advocacy, there are actions that you can take on 2 bills. The first is HB 965. It's entitled the Show Me Healthy Babies Program. It's sponsored by Lakeisha Bosley of St. Louis, and the Show Me Healthy Babies program is administered by the Missouri Department of Social Services, and it supports pregnant women and their unborn children by providing access to health care up to 60 days after the birth of a child. This bill would increase the length of the program from 60 days to 1 year after the birth of the child. This program is intended for women who have household income up to 300% of the federal poverty level and who are not eligible or do not have access to private or other state-funded health insurance programs. This bill could dramatically improve access to health care for vulnerable mothers and their newborns. And the second bill is actually one that we mentioned last month. It is HCR 14. It's a joint resolution that urges specific actions to address the economic and public health crisis caused by systemic racism and which has been greatly magnified by the COVID-19 pandemic in Missouri. Systemic racism and structures of racial discrimination create generational poverty, perpetuate debilitating economic, educational, and health hardships, and they disproportionately affect people of color, causing the single most profound economic and social challenge facing Missouri today. So we ask you to contact your legislators and ask them to support both of these bills, along with key members of House leadership to ask them to assign these bills to committees. We will provide the information to your legislators in a follow-up email. I also want to say thank you to the many people who followed up after last month's program. We asked for action on HB 627, the Show Me Child Development Account Program. And the sponsors were thrilled with the level of support for the bill, and it was voted do pass by both the House Emerging Issues and the House Rules Committee. So the next step is to bring it up to the House floor for a vote. So I know I sound like a broken record, but to keep this bill moving, we ask that you please contact Missouri House leadership and ask them to bring this bill to the floor. We'll send you contact information and talking points on all of these issues in a follow-up email to make it easy for you to take action.
Thank you, Amy. You will never be a broken record. We really appreciate your strong advocacy. I'd also like to say that we know that there were some sound difficulties with that wonderful interview between Jeannette and Courtneisha, and we're going to try to make a transcript of it and send it out when we send out some other materials to all the registrants. And thanks again. We all struggle with this new format. At this time, we'd like to open it up for questions from our participants. So if you have a question for Riisa or for Jeannette, or for Cornisha, please type it in the chat. We'll get to as many as we can in the very brief time we have allotted. And most of you, I think, are familiar with the chat.
So Susan, to start us off, we did have a couple of questions in the chat. The first one is for Riisa, and she was asked, she'd love the questioner would ask how the RHC looks at health disparities across the lifespan. This questioner is a new team member with Generate Health Flourish and thinks a lot about racial disparities in infant and maternal mortality.
Thank you for that question. First of all, I'd like to say Generate Health is a phenomenal partner, and we are really engaged with the work that you all are doing and try to partner closely to elevate the work that you are doing. Our data that we collect is directly from each of our healthcare providers, and so it does cover the health span based on who they serve. So if you look at our access to care data books, the data is broken down by age across lifespan and also across different disparities or different disease and across different service providers. I hope that answered your question.
Another question in the chat is, Riisa, in your opinion, where are the most profound gaps in the healthcare system?
That's a really good question. The one that we find to be most profound and that we hear all of the time is around access, right? But that in itself is really loaded. So when we dig deeper into that conversation and try to understand what does access mean and what's preventing it, some of the things that we hear often are transportation to get to. Like, where is something physically located? How do you find resources to be able to pay for what is needed specific to the healthcare that you desire? Dental has been a huge issue that we've heard, frequently a recurring issue. We've also heard and have recently moved into the chronic pain and understanding how do you manage chronic pain and find resources and providers who will tend to those needs. So those are some of the things top of mind that we hear our stakeholders mentioning.
Here's another one for you, Riisa, kind of a hypothetical, but if universal health care was passed tomorrow, I assume access would still be an issue until facilities are opened in underserved communities. Do you believe that universal health care could solve the lion's share of the racial health divide?
Ooh.
That's a little loaded, I don't know.
Question. Personally, Riisa's opinion, universal healthcare can go a long way into addressing some of those healthcare issues. One of the things that I constantly press on is how are we informing where we put resources and how we allocate our resources and interventions. You see healthcare providers pop up all the time, but are they in the places that data show have the greatest need? Can we align our data so that where we see the need exists and where we see the greatest number of instances of mortality and illness, that should be where, so we're not going to get to the issue around disparity until we start to align the resource with the need.
Thank you. Someone has asked for more information on the Community Champions program. I'm not going to have you answer that, but I'm going to have you've been posting PDFs. I'm going to assume you have more for me, and I'm going to include everything that Riisa is sending in our follow-up. So you will have an easy access to all of them. And I'm going to ask you one last question. It's a coordination question, and is Prepare STL coordinating with the Regional Coronavirus Pandemic Task Force, hospital providers? And is there an opportunity for partnership there if it doesn't exist?
Awesome, great question. The current campaign that we're on that I spoke about at the end of my talk is in partnership with Prepare STL and the Regional Response Team. We have members on each of those entities that serve on the Pandemic Task Force. One of my soapboxes is that we have to be aligned. We have to understand all of the trains that are moving and figure out how to leverage what's happening so that we can provide the greatest impact and resource. So we're always looking for opportunities to collaborate, not reinvent the wheel, but to amplify good work that's being done and find where we can augment it.
Great. I think I've covered most of the questions in the chat. If anybody has a question specifically for Cornisha, let me know by just going ahead and unmuting yourself and asking it. And if not, we will move on to the next part of our program.
I wanted to say one last thank you to all of our speakers, Reverend Pupillo, Riisa Rawlins-Easley, Jeannette Cooperman, and last but not least, Amy Hammerman and Cornisha Rogers for sharing your time, talent, and passion with us. As has been mentioned, you will be receiving a follow-up email to all of those who you are watching with links to the action items and additional resources that were shared today. It's now 1 o'clock or a little after, and we know that some of you may need to leave us. For those who are able to stay, we invite you to spend some time in a small group to give you some time to process all that we have heard in the last hour. While you're in your groups, please consider these two questions. 1, what is the main thing you take away from today's presentation? And 2, what is one thing you will do tomorrow to address what you have heard?
Thank you so much.
My name is Cheryl Adelstein, and I am the Deputy Director of the Jewish Community Relations Council. I've been talking in and out through this today, but I haven't actually never remembered to introduce myself. So I just want to thank you all for being with us today. I want to thank Susan Block, who was our moderator. Susan is an attorney, and she had a court date at 1:30, so she ran off to take care of that. We hope you found it useful to go into breakouts and process what we learned. If anyone decided something about what they're ready to do tomorrow to address what you heard, go ahead and type it in the chat. Maybe we'll read a few before we sign off here. Our next program will be on April 14th at 12 p.m., where we will be addressing the systemic racism around environmental concerns for people of color in St. Louis and beyond. We hope you will join us then. Thanks again to all our speakers and co-sponsors, and have a safe and pleasant day. And the one action I'm seeing is contact my state representatives about bills, and we will provide that in the follow-up. So thank you for doing that. It made a big difference last time. Everyone have a great day, and we will hopefully see you in April.